Now we move on to our next topic, which is clinical Vignettes in GI and liver cancer, a case-based panel discussion. I would like to invite the moderator, Dr. Manav Wadhawan, on the stage. The panelists for the session are Dr. Simmi Dubey from Bhopal, Dr. H.P. Yadav sir from Indore, Dr. Shaifali Bansal from Bhopal, and Dr. Mohammad Talanur from Indore.
Good afternoon. So let me welcome my eminent and very learned panel.
Manav, can I just take a minute? All the PGs who have presented posters, the judges have gone there. They can go to the poster area. Thank you.
All right. So I've been asked to talk about liver abnormalities and GI cancers as in clinical cases. I have a very learned panel with me. So my job is very simple. I'm going to put up some clinical cases and let the panel do all the discussion. I would welcome the audience to ask questions in between if they have any queries rather than waiting till the end. So before I go to the cases, just a brief background. When we look at liver function tests, we are not looking at bilirubins, ASTs, ALT. We are looking at classifying the nature of injury which the liver has undergone. So we can broadly categorize liver function tests into 4 categories. So I would consider tests which assess liver cell injury, which is primarily bilirubin, AST, ALT, test for detecting cholestasis, where gamma GT and alkaline phosphatase come into picture. You have synthetic function tests, which primarily are albumin and bilirubin, but here I would like to mention that platelet count becomes a very important liver function test. Now it's not exactly a synthetic liver function test, but it tells you about portal hypertension. So in your clinical practice, the moment you see a low platelet count, your mind as a gastroenterologist should think that does the patient have a liver disease or a portal hypertension or not. So, and finally, albumin and prothrombin time, which actually indicate the liver synthetic functions. Liver morphology tests also are a part of liver function tests. So your cross-sectional imaging like CT, MR, fibroscan, ultrasounds are also a part of liver function testing. So with that background, let's straight away move to the cases. So we come to case number 1. 40-year-old gentleman, anorexia, nausea, vomiting and jaundice for 10 to 15 days. No past history of jaundice, no blood transfusions, no surgery. Now this guy has been taking regular alcohol for last 15 years. Almost 3 drinks a day. There is no other history of any other drug intake, allopathic, Ayurvedic, Unani, or any complementary alternative medications. On examination, he has icterus. He has a 3 centimeter soft hepatomegaly, no spleen, no free fluid. This is a liver profile. Bilirubin of 7.8, SGOT or AST of 564, ALT of 808. Gamma GT is mildly raised, albumin is 3.6, platelet count is normal. So let's start with Dr. Shaifali. Dr. Shaifali, I've just listed out the diagnosis. What would you consider as the first diagnosis, sir, and why?
Sir, I would like to dissect all the options that you have given. Considering the history of alcohol hepatitis just does come to the mind. But when we look at the ratio between AST and ALT, then there has to be a ratio of 2:1 in patients of alcoholic hepatitis, which is not there in this case. The second thing is, when there is alcoholic hepatitis, usually the enzyme levels do not exceed 500. Here they are gone up. So, though alcohol is there in one of the options, I would still keep it much lower down. My first option would be acute viral hepatitis in this patient, considering the prodromal phase of symptoms that he has had, followed by icterus, followed by tender hepatomegaly, where there is a rise in the liver enzymes, where the SGPT is much more than the SGOT. So my consideration would be viral hepatitis. As for the drugs, you have clearly mentioned that there is no history of any drug intake. So again, that goes down.
So let's be, I'm reiterating what Dr. Shaifali has told us. AST-ALT ratio is probably the most important factor which speaks against alcoholic hepatitis here. Your AST is usually more than 1.5 times the ALT. Here is the other way around. So AST-ALT ratio defines alcoholic hepatitis and cirrhosis. So even with this kind of liver enzyme picture, it is unlikely to be cirrhosis. And this patient anyway had a soft hepatomegaly, so cirrhosis is very less likely. So this is something which I thought I must highlight. the moment you see a level of AST, ALT more than 10 to 20 times upper limit normal, there are only few differentials. You literally rule out almost all causes except these 3-4. So acute viral hepatitis is one, drug-induced liver injury is second, and third is acute ischemic hepatitis, which you often see in post-operative patients. Somebody has hypotension, you get a referral from a cardiology unit for deranged liver functions. You see enzymes in the range of thousands. So that's a setting. This patient does not have that setting, but acute viral hepatitis is what this patient had. So the first take-home message is, not all patients with chronic alcohol intake and jaundice have alcoholic liver disease. So kindly remember that just because the patient is taking 3 drinks a day does not mean that he has alcoholic hepatitis. You need to see other factors. Alcoholics are actually as prone or maybe more prone to have other liver diseases than a usual patient who has a normal liver. And drug history should be taken in all patients. Second case, this is a longer one, and this has a lot of messages. I'll just describe the case and then we move on to the panel. So 43-year-old obese diabetic, this is a guy you will see every day in your OPD. Absolutely asymptomatic. On executive health check, you see a raised AST, ALT, and he comes to you for follow-up. Otherwise, he doesn't have any symptoms. There is no significant past history. There is no alcohol intake. And that's the profile. Bilirubin of 1, AST 128, ALT 90, gamma GT 2 times raised, albumin slightly low, and platelet count 90,000. We do an ultrasound which shows grade 2 fatty liver, portal vein of 10 millimeter, there is no spleen. Dr. Yadav, what would you think about and how would you proceed in this case?
Here we have an obese diabetic patient, mildly raised SGOT, SGPT, and no other significant history. So here there are few differential diagnoses. Obviously, the patient is obese diabetic. We should consider fatty liver disease, NAS. And before labeling any patient with NAS, we should consider other causes also, like chronic viral hepatitis, hepatitis B, hep C. They can also cause similar mildly raised asymptomatic enzymes. And other things are drugs. And when we talk about the drugs, the patient is diabetic, may be taking some drugs. And other than this, it's important today's practices. The patient might be taking some healthy juices and some multivitamin containing other than some Ayurvedic preparations also. So we should ask about all those things because this type of can be seen in many conditions. So important are drugs, NAS, chronic viral hepatitis. These are the important causes. Other than that, some less common causes like the patient is younger one, then can have Wilson's disease, female, then obviously autoimmune is less likely because usually they are symptomatic.
So Dr. Yadav is trying to tell you that just a fatty liver on ultrasound does not preclude other investigation for the cause of liver disease. You still need to rule out hepatitis B and C. Of course, you've already asked about alcohol. You still need to do autoimmune markers. This is a guy who has significant liver disease. Right. So your workup has to be complete in the evaluation of this patient as an etiology, and once you rule out others, then you rule in a diagnosis of what we call MESLD or NASH these days. So the viral markers in this guy were negative, hepatitis B and C. He had dyslipidemia. So another very important thing, investigating a fatty liver, you have to look at the metabolic profile. You have to look at dyslipidemias, you have to look at fasting blood sugar and HbA1c. So you actually may find a normal sugar but HbA1c of 6.5. That also is an indication that this guy probably has a metabolic syndrome predisposing to the liver disease. So non-alcoholic fatty liver disease. Dr. Simmi, would you stop here or would you do anything else? You have a diagnosis, you have ruled out all other etiologies. This guy has fatty liver disease. Would you start treatment for the metabolic syndrome or would you like to do something else for this patient?
No, definitely. We are not going to stop here and we have to find out at what stage is this non-alcoholic fatty liver disease is. And for that, we have to go with certain other tests also. It includes invasive or non-invasive tests. And now recently we are OPD test which is available non-invasive, that is the FibroScan, and we definitely go for it. And this procedure actually takes very little time and give us an idea what is the stage of non-alcoholic fatty liver disease and what is the stage of fibrosis in this patient, at what stage it is, so that we can further plan the management of these patients.
So any patient who has significant liver disease, fibroscan has actually become stethoscope of gastroenterologists. So we would do fibroscan for every single patient with a suspected chronic liver disease. I'm not talking about acute viral hepatitis here because there it will be fallaciously high. But wherever you suspect a chronic liver disease, cirrhosis or no cirrhosis, you want to do a fibroscan to assess the degree of fibrosis in this patient. Previously we used to do liver biopsy, but that's actually defunct these days. We nowadays don't do a liver biopsy for assessment of extent of disease.
Manav, any level of bilirubin where you feel that fibroscan may be faulty?
So anything above 2.5 probably fibroscan is going to give you a very high value. Similarly, AST, ALT value above 150 or 200, fibroscan is going to be fallaciously high. So you should limit your fibroscans in a patient who does not have jaundice and ASTs are below 150, 200. So we did a fibroscan. The fibroscan came as 36 kilopascals. Remember, this guy has a AST of 120 and bilirubin of 1. So this is likely to be a true value, not a falsely high value. We did do a liver biopsy. In this case, this is an older case which I am discussing. Nowadays, we have stopped doing biopsies with the more and more experience in, more and more confidence in assessment of fibrosis by fibroscan. The biopsy confirmed the presence of cirrhosis. So this is a NASH-related cirrhosis which is compensated. Dr. Noor, what do we do now? Any more investigations, or we tell the patient start treatment and go home?
So at this stage, once we have confirmed the presence of cirrhosis, then we need to screen for varices, because many of these patients can have significant large varices. They can be, so if they have large varices, then portal hypertension reducing agents can be added, beta blockers. And at the same time, it is very important to rule out SCC in this patient, because some of these patients can harbor, so we have to do alpha fetoprotein levels, and if they are raised, then doing a triple phase CT scan at the time of diagnosis is also important to rule out SCC.
So two very important points Dr. Noor has raised. Please remember, if it is not cirrhosis, your evaluation stops here. You don't need an endoscopy, you don't need any further imaging, you already have ultrasound with you. But if you diagnose cirrhosis, it is mandatory to screen for varices because your treatment changes. Lower risk varices, you add a beta blocker. Higher risk varices, you do a banding and a beta blocker. So your management now depends on whether the patient has portal hypertension or not. Secondly, cirrhotics have a high risk of HCC, so you also screen for hepatocellular carcinoma. Now I want to initiate the audience to this new concept of an abbreviated MRI. Nowadays, we understand that ultrasound is not a good investigation to screen for HCC. We also understand that contrast CTs and contrast MRs are expensive and you need to give contrast, which itself can cause problems. Now, there is more and more literature and more people are doing abbreviated MRI. Now this is a very limited number of sequences you do. You don't give contrast. You only ask for 3 imaging, T1 weighted, T2 weighted and diffusion weighted. And based on that, it gives you a much better sensitivity of HCC as compared to an ultrasound. If your abbreviated MRI is normal, that means no suspicion of a nodule, you don't need to do a contrast imaging. The cost would be 1/4 or 1/5 of the regular MRI because the total time it takes is 10 minutes. You're not giving contrast, you're not taking extra time on the MRI console. So please ask your radiologist, if it is not done at your place, kindly start doing it. It is slightly more expensive than an ultrasound, but much better information is provided by abbreviated MRI.
One clarification, we'll be doing CT or abbreviated MRI in all patients who have cirrhosis, irrespective of alpha fetoprotein, I think.
Yes, sir. So I'm not talking about CT here. CT without contrast will not give you information, and you don't want to give radiation also to this patient. There was a debate whether you actually want to do a cross-sectional imaging with contrast or not in a patient where you have a low index of suspicion. With the abbreviated MRI, the things are changing. It is still not in protocol, but that's what most of us are doing now. Abbreviated MR, no radiation, no contrast, 10 minutes job, twice as expensive as the ultrasound. So your ultrasound would cost you 500, 700 rupees. This will cost you 1,000, 1,500 if you are doing enough volumes.
But AFP doesn't come in algorithm. That is what I am highlighting.
No, AFP is always done.
No, it is done, but irrespective of whether it is normal or raised, you will do imaging.
Absolutely. Why?
This is
Because
very
alpha
important.
fetoprotein is positive in only 25 to 40% of small tumors.
No, the
3/4 of the small tumors will have a normal alpha fetoprotein.
The sensitivity of abbreviated MR is equivalent to triple phase CT.
Sensitivity and specificity are two different things. So sensitivity is as much as a cross-sectional imaging, the specificity is not. So it will even pick up regenerative nodules and tell you this is suspicion. You still need to confirm with a triple phase CT, but in 90% of cases, you will save a cross-sectional imaging in these patients. You understand what I'm trying to say?
Yeah.
So a lesion, if there is no lesion, no suspicious lesion, you don't need a cross-sectional imaging. And that will be true for 90. So what ultrasound does for you, abbreviated MR does better.
So there was a, hi, can I come in?
Yeah, Ashish.
As per his question about sensitivity and specificity, there was a large study done at PGI Chandigarh where they showed that sensitivity is more than 98%.
Yeah, 98%.
And specificity was 100%. So very good mortality.
Yeah.
But only thing that most of the radiologists are not tuned to it. They need to know how it is done.
So, I would urge all of you to go back to your radiologist and ask them to read about abbreviated MRI. That is the new concept of screening for HCC without increasing much cost here. So we did screen this guy for HCC, and as luck would have it, he had a 2 centimeter lesion in the right lobe of liver.
Manav, I have 3 issues.
Sir.
One thing, we have already incorporated fibroscan because it is done left and right in India. But
Right,
what
sir.
about some non-invasive markers like FIB4, which have been included in the algorithm a step ahead of LSM? It is much cheaper to do also, but people are not doing it. Second is utilizing Bovino 7 criteria for using LSM to decide when to start beta blockers. There was a time when for pre-primary prophylaxis, that means where patients do not have varices, we never give beta blockers. But now in this situation, those patients who do not have varices must still have that particular LSM criteria which says that, well, it is high. So should we start beta blockers at that point of time?
So next time you have to give me 1 hour for this presentation, then I'll discuss all these issues, sir. The point you are raising is absolutely fine,
And
sir.
third is 20% of the patients who have NFLD develop HCC without developing cirrhosis. Do we
Exactly.
have any surveillance guidelines for those situations?
Very important questions. As I told you, I need more time for this. I'll only answer the third question here, sir. It is very well known that today the commonest cause of HCC in a non-cirrhotic patient is NAFLD, not hepatitis B, because hepatitis B is already under control, reasonably under control. We cannot have surveillance guidelines because we don't have enough data to say when to do it. And if you include or NAFLD patients, then you will be screening 50% of your population. In urban cities, 50% of population has NAFLD. So it's not feasible, and we don't have literature to support, as of now, the screening. Let's move on. So this patient, asymptomatic, comes to your OPD and turns out to have a HCC. Can you predict this based on the investigations, the first investigation you saw? So this guy, let me take you back to the LFT which we saw. I will draw your attention to 3 facts here. Look at the ratio of AST-ALT. So Dr. Shaifali in the last case told us that AST-ALT ratio is a predictor of alcoholic liver disease. I told you it also predicts cirrhosis. Here the AST is more than ALT, the ratio is almost 1.5, 1.4. Secondly, albumin is on the lower side. Thirdly, platelet count is low. So this LFT and platelet count actually gave you an idea that you may be dealing with a cirrhosis with portal hypertension. So if you carefully look at the liver function test, more often than not, on the first visit, you will be able to counsel the patient, boss, ye investigation mein karne wala hu aapki, provided that these things come out positive. So that's one important thing to remember. So from case 2, the take-home message is NAFLD and NASH may not be as innocuous as it initially might seem to appear. You can have cirrhosis in significant number of patients, and many of these guys actually have HCC. If you have any doubt about presence of advanced liver disease, even in an asymptomatic individual, please get a fibroscan. Biopsy, I would not advise to do now, but fibroscan is mandatory for evaluation of any patient who has suspected chronic liver disease. Secondly, thirdly, endoscopy and HCC if you diagnose cirrhosis. If the patient only has advanced fibrosis, no cirrhosis, you do not do endoscopy or a abbreviated MRI. Let's move on to case number 3. We have 11 more minutes. I think we should be able to cover all our cases. So, this is a internal medicine case, ma'am. 61-year-old male presented with pain abdomen for 2 months, gave a history of shortness of breath on exertion, no alcohol, no history of jaundice, no nausea, no hematuria, no melena. And this is an investigation profile. Hemoglobin comes as 5.8. That explains the shortness of breath. TLC is normal, platelets are normal, LFTs are almost normal except slightly raised gamma GT, and albumin is 3.4. What do you want to do next, ma'am? Anemia with
We
pain
have to
abdomen.
evaluate anemia in an elderly male, 60 plus. 60 plus presenting with anemia for the first time, the first thing which comes to my mind is to rule out a GI malignancy. I would advise a upper GI and a lower GI scopy, in addition to the routine investigations which you have said before the invasive procedure.
So this is a patient who gives no history of melena.
And sir, even you have said, yes, so there's no history of melena, no history suggestive of a GI bleed. I would like to go for the routine investigations before.
Exactly. So,
and type the anemia.
Type the anemia. So
Type
most
the
important thing here would be to type the anemia first. Look at the peripheral smear. So single most important investigation which we forget to do as a specialist is a peripheral smear. We see a CBC, we don't look at the MCVs, we don't see a peripheral smear. Please remember to look at peripheral smear. The information which you get from a liver function test in a liver disease patient, similar information you get in anemia in a patient who has from a peripheral smear. So it's a very important investigation. So we did a peripheral smear, we did a retic count, we did a B12 level, we did serum iron levels. We also checked for stool occult blood and a ultrasound. And this is what we find. Dimorphic anemia with hypochromasia.
Anemia with a deficiency of both B12 as well as iron, and the stool occult blood is negative. But sir, a single report of stool occult blood negative does not rule out a GI malignancy and does not stop me from doing investigations for a GI cause. At least 3 serial stool samples to be done, and we do treat B12 levels. We will try to correct the iron profile and try to see if the anemia improves. But if there is a lesion underlying, you have to keep a strong focus to rule out that investigation, to do a upper GI followed by a lower GI after correcting B12 and iron would be my.
Dr. Simmi, your comments, please.
Yeah, that's very true. So actually B12 iron, we later on, first we simply go with the peripheral smear and reticulocyte count, because we have to see is bone marrow functioning normal or not, is it suppressed despite of anemia. So definitely reticulocyte count is 3%, peripheral smear gave us a dimorphic anemia picture. Then we go for all these levels, whether B12, folic acid and iron, plus stool for occult, definitely we will go to assess the loss. Then here we have to pay attention at the USG abdomen, which is giving us few lymph nodes. So this alarms us that what is going on? What is the cause of deficiency of B12 and iron actually? Are we going with some small bowel disease? Something is going on which is hampering the absorption of both B12 as well as iron. Or it is a simply stomach disease also. So absorption is hampered. That is the cause of deficiency. So here further investigation is needed.
So I am so glad that I don't have to answer anything. My panelists are so learned that they're telling you everything you require.
And one more small thing, Dr. Manav.
Sir.
And in India, we should not forget the worm infestation. Obviously, it's a conference of cancer. We all are thinking for cancer. But worm infestation is very common. And many times we get the patients related to
so every panelist agrees that we are looking at a small bowel pathology here. So let me give you a fact. Vitamin B12 levels would be deficient in 80 to 90% of urban population. Nowadays, this was not there 20 years back. Dr. Asmit will remember when we were doing our MD, we were told that nobody has vitamin B12 deficiency in India. Nowadays, 80% urban population has B12 deficiency because of the RO water which you are using. It takes away every vitamin and mineral from the water which you are using. So unless the patient is taking vitamin B12, B12 will be deficient in almost all the patients. Dimorphic anemia still shows a low serum iron level. You still have to suspect a GI bleed here. Patient may be losing because of worms or a malignancy or anything or absorption defect. So you label it as nutritional anemia, maybe fallacious, maybe going overboard. You have to investigate further. So Dr. Noor, what would you do?
So, in this patient, as we would like to do further imaging to rule out GI malignancy, for which routine.
So my question to you is, would you do a imaging first or upper GI colon first? The other panels seem to believe that upper GI colon should be done before the cross-sectional imaging, which actually what we did.
If we have to do both, then proceeding from non-invasive to invasive would be an ideal approach.
I completely agree with you. So you can actually debate either way, whether CT first or upper GI colon first. We actually believed the ultrasonologist, and we went with the upper GI colon first. We thought that the ultrasonologist has been able to screen the abdomen in a good way. We did upper GI, which was normal. We went with a colonoscopy expecting to take a biopsy from the ileum to look at what is going on, and this is what we found. Ulcerated lesion in the right colon, deep ulcer, punched out ulcer. If you look at this picture, the rest of the colon is almost normal. It's not a concentric lesion. It is not something which is causing thickening there. It's only in the involved area where you see the ulcerated lesion. Then we went ahead and did a cross-sectional imaging. So as I said, we can debate either way. We can do a cross-sectional imaging first or a upper GI colon first. This is how we went. And because we were suspecting malignancy here now, we straight away went with a PET CT whole body with CECT abdomen. So there has been a lot of debate about whether to do a triple phase CT first or a PET CT first. We combine it nowadays. You do it in the same setting. If you think there's a suspicion of malignancy, you do a PET CT and you do a triple phase CT along with that. What is the debate in that? So I thought I'll just clarify that in the presentation. This is what we found. Right colon, significant thickening. You can appreciate the lymph nodes around the right colon, and you can appreciate periportal lymph nodes. So this guy actually had multiple abdominal lymph nodes. He had eccentric thickening of right colon. We took biopsies. And we found out a high-grade T-cell non-Hodgkin lymphoma. Can you believe it? Somebody comes with an iron deficiency anemia, and he turns out to have a T-cell non-Hodgkin lymphoma without involving bone marrow, without any blood involvement. So TLC was normal, platelets were normal, and the hemoglobin deficiency was because of bleed from the ulcerated lesion. So that's one case I thought we should share. This is a guy we recently saw around 2 months back. So the take-home messages from this case: all iron deficiency anemias should be investigated with upper GI colon, every single. So even if you have a dimorphic anemia, but you see a low iron and you see microcytes, please investigate for GI blood loss. Stool local blood, even 3 samples are not good enough to pick up bleeding because the bleeding is intermittent. It may not happen for 7 days, it may happen continuously for a few days. And we also remember that 60 ml of blood loss is required to cause a melanic stool. So absence of melena does not help you. Stool vitamin B12 deficiency is more common than what we think. And finally, on an ultrasound, the bowel evaluation may be inadequate. It depends on the observant radiologist will pick up more bowel lesions, but it is often very easy to miss a bowel lesion on an ultrasound. The sensitivity is not as much as you have a solid organ lesion. We have 2 more minutes. It's a very small case. I just wanted to make one clinical point here. That's the reason I took this case. So I will invite opinion of both the gastroenterologists here on this case. So 59-year-old male patient, doctor, referred from Aligarh for jaundice and pruritus with an ultrasound saying that there is a CBD stone stuck at the lower end of CBD. On closer examination, the patient did not report any history of fever or of pain. Bilirubin was 12, gamma GT was 658. So, Dr. Yadav, would you straight away take up this patient for a ERCP? You already have an ultrasound report, CBD stone stuck at the lower end, but patient does not give any history of pain abdomen, patient does not give any history of fever. Would you straight away take up for ERCP, or would you like any further investigation before you go?
Stone disease, there are few things which are odd in this patient. One is usually there has to be some pain, stone is stuck down, and that may or may not be cholangitis, but stone, there has to be some pain. And that's the one thing in history. So ERCP is a therapeutic procedure and should not be taken as diagnostic. So we should do further imaging in this patient.
Absolutely. So your clinical sense dictates what you do next. It will be very easy to just go in, do a ERCP, put a stent, and say that the CBD was cleared and patient will be fine. And 6 months down the line, he'll come back to you with the metastasis, and you will be cursing yourself that this guy did not to start with give me a history of pain. It is very unusual for CBD stone to cause cholangitis without any history of pain. So this is what we found. You can appreciate an enhancing lesion at the lower end of CBD on cross-sectional imaging. We did a side-wing endoscopy, and this is what we found. The mucosa over the papilla was absolutely normal. But you can see a bulky, bulging papilla. All we did was took a lot of deep biopsies in this patient, and the biopsies turned out to be negative. What would you do next? Dr. Noor, you would repeat a side wing with deeper biopsies? Would you do a ERCP with brush cytology? Would you do a EUS or an FNA?
So several options are there. Obviously, if the overlying mucosa is looking normal, then repeating biopsy will not be very
may not be as effective as, because we have already taken deep biopsies.
Another thing can be pre-cutting and then taking deeper biopsies. And then obviously brush cytology and the EUS with FNB or FNA can be an option.
So generally in such a scenario, you would prefer a EUS FNAB over a ERCP for a simple reason that you don't want to do an extra therapeutic procedure. You don't want to cut the papilla and then take biopsies and cause bleeding from the suspected tumor. So this is what we did with the EUS, and you can appreciate this 2 centimeter lesion seen right below the papilla. We took biopsies, FNAB confirmed adenocarcinoma. And as luck would have it, on the day we did the FNAC, same day evening he developed cholangitis. High grade fever, bilirubin shot up from 12 to 18. And we had to go and do a ERCP. Now last question, before we go ahead, anybody can take up. Would you do a SEMS or would you do a plastic stent in this case? What would be your choice?
Here the idea is to treat the cholangitis. This is a periumpillary or lower CBD tumor. Even if you put a small stent, 6 centimeter, that is not going to interfere with your with the surgery and doing the anastomosis at higher level. So small stent can be placed, but most of the time in such cases, lower CBD obstruction, practically and clinically, there is plastic stent also work well, particularly for lower end obstruction. Obviously, we can use metallic stents also.
So, what do we need to remember is that in a tumor, when
should be below the hilum.
So you basically want to relieve cholangitis as soon as possible and not interfere with the surgery. Now this guy is anyway going to undergo a Whipple. So even placing a metal stent does not make a difference. And metal stents are bigger, they cause better resolution of cholangitis, so we decided to place a metal stent here. And the patient was operated after 5 days. We found out a T2 lesion without any lymph nodes, and he's good at 1 year of follow-up. I would stop here, and any questions from the audience, we are happy to answer. The panel here is happy to answer. Thank you.
So, one small question. This patient of iron deficiency anemia, sometimes we see the patients with iron deficiency anemia, upper GI lower normal, lower GI normal. So what is your protocol for further evaluating? Would you still immediately go for evaluation of small bowel by doing capsule?
So we would do a cross-sectional imaging. If the cross-sectional imaging, a CT scan is a normal or a MR is normal, we probably don't do a capsule here. Unless we are sure that he is bleeding. Then we would ascribe the anemia to probably a iron absorption defect. B12 was also low, irons are also low. On the other hand, if you find, as a routine, we'll also take biopsies from the terminal ileum. Very often than not, more often than not, you'll find terminal ileitis. You treat that, you give iron. Question of doing a capsule, I would say it is optional. Some people would do it. We generally reserve it in case we suspect a lesion.
So, one clarification, sir. Here.
Yes.
Sir, it's a dictum that never leave a obstructed biliary system undrained. So the moment we were doing USFNA, I would have actually done ERCP simultaneously and prevented this cholangitis first. And second, it would have exposed the lower CBD, and I have taken, even my FNAC would have been inconclusive. My biopsies would have been given a positive diagnosis. So you're lucky that you got FNAC positive.
No, FNAC. So, see, there are different ways of approaching. There's nothing wrong in what you are describing. It can be done that way. The patient, we planned that we have rows. We actually diagnose malignancy on table. We do FNAC, the pathologist is there, he tells us adequate tissue is there, we can see malignant cells. And we planned for a surgery within next 48 hours. I don't want to make a papillotomy there, make the tumor bleed, make it more complicated. What you're saying is right. This is one way of approaching things. Our way is different. And FNAB with a bigger needle is as good as a biopsy. And more often than not, you're able to reach a diagnosis. The US experts here would vouch for that.
You use the 22G or 25G in duodenum when you are in a short?
No, we use 22G.
22GB.
Yeah.
I think we can cut it off here.
So we can discuss this over lunch. Any more questions?
Yeah. Thank you so much,
thank you.
Manav.
Thank
that
you.
was an excellent clinical learning. I think he needs a big applause. Thank you all the panelists also.